أنا بتشرف بوجودي في المؤتمر دوت، حتى لو كانت ظروفي ما تسمحش، وبشكر التكنولوجيا اللي خلتني إن أنا أقدم المحاضرة من هنا. بشكر أساتذتي كلهم على المنصة وشكرا للتقديم. وهبتدي في محاضرتي، والنهارده بتكلم على حاجة براكتيكال اللي هو الهاي فريكوانسي فنتيليشن، how to get the best of it. طبعا لما بتكلم عن الهاي فريكوانسي وبيسالوني ليه بتحب الهاي فريكوانسي، لان انا قعدت سنين اتعلم الهاي فريكوانسي على يد عمالقه في الهاي فريكوانسي فنتيليشن، ومن ضمن العمالقه اللي انا بشرف دايما ان انا اكون متتلمذ على ايده استاذ دكتور هشام عوض ودكتور عادل رياض، موجودين معانا في احد الكورسات بتاعت الفنتيليشن. I'm working in I'm a consultant neonatologist in Latifa Hospital, which is a tertiary center in Dubai, with around 7,000 annual live births. With 20% of them are preterm, and out of those preterm, 65% are late preterm. As I told you, we are tertiary center. We are having nitric oxide. We are having the therapeutic hypothermia, but we don't do the cardiac surgery. That's why we are level 3 care. I have nothing to disclose or declare in this presentation. As you know, the high frequency ventilation, we are having different kind of ventilators, and it depends on the ventilator that you are using frequently at your place. My objective during this presentation, or this 20 minutes, it will be about the physiology of the high frequency ventilation, the indication, and how to adjust the ventilatory settings in one case scenario. Because of the time, I will not go to the second case scenario. So as we know that we are having different modalities of ventilation, and thank you for Dr. Sharif who presented the non-invasive mode of ventilation, which is booming now everywhere. So we are having the non-invasive mode. It is one of the modes. We are having the invasive modes of ventilation, and we are having the high frequency mode of ventilation. So which ventilation we should use? My advice and the advice of the pioneers of the ventilation is to use the ventilator that you are depending on and using successfully without any complication. So it is whatever convenient for you, you should use it. The bottom line for the clinician, so we should assure that the patient will receive the minute volume that it is appropriate for the gas exchange and will satisfy the patient needs without damaging the lung and will not cause any circulatory impedance or impairment and will not increase the patient discomfort. So what are the goal of mechanical ventilation? We are having two goals. So first one is the oxygenation, to give appropriate oxygenation and appropriate ventilation. And this will be done through establishing the functional residual capacity, then to maintain the adequate functional residual capacity that will improve the compliance, improve the gas exchange, and reduce the pulmonary venous return with minimizing the lung injury. You can see here from this diagram or this cartoon that we are having two main points here, the critical opening pressure, and here will be another point which is called the critical closing pressure. Here is the critical closing pressure. Once we reach it, we will have a collapsed or atelectatic alveoli. So the critical opening pressure, if we continue giving more pressure, it will lead to over distension of the alveoli, and this is one of the traumatic zone of the ventilation, and the other one is the atelectatic zone. So the aim of this is to let us know that we should ventilate the baby between the critical opening pressure and the critical closing pressure. So what is the difference between the in conventional ventilation? I'm not against the conventional, but if we can ventilate with the conventional in the green area, so I'm giving the best outcome for the baby without causing the over distension or the injurious zone of the curve. While I'm using the high frequency ventilation, I'm using a sub-physiological tidal volume, even less than the dead space, with a supra-physiological rate. And this, I'm improving the name of the rate. It is wiggling rather than the rate, because the rate is a cycle of inspiration, expiration. And as we'll come to know here in the high frequency ventilation, that it is, especially with the active exhalation, it is both will happen in the same time. Let's see this diagram. This is the alveoli. If I'm not giving the proper pressure, I will cause atelectatic trauma, and this will cause, if I'm causing repetitive atelectatic trauma, I will cause shearing of the alveoli. And again, if I'm giving a higher pressure, I will cause a volutrauma. And again, I will cause shearing of the alveoli that will lead to pulmonary interstitial emphysema or the chronic lung disease or the lung injury. So the history from the nature started by observing the animals. The dog, after running, the dog are panting. They are not breathing, so they are panting. Same, it happened for the hummingbirds and the horses at the end of the race. All of these were panting at the end of the race, or after a long fly, or after a long ride. So they realized that if these animals are panting and they are alive, why we cannot implement this into life? And this was started in 1981. And after that, multiple clinical trials have been published, and it is used successfully in the neonatal and pediatric units. What is the difference between the conventional and the high frequency ventilation? It is the rate, first of all. Conventional is having a rate, while here is having a hertz or a wiggle reaching up to 900 hertz. While the tidal volume is ranging between 4 to 6 ml per kilo, and here it is 0.1 to 0.5 ml per kilo, even less than the dead space. Sorry for the typing mistake here. The alveolar pressure is more than 50 centimeter water, but here it is barely reaching 5 centimeter water. In the high frequency ventilators, we are having modes also. So we are having the high flow positive pressure ventilation, the high flow interrupter, the high flow jet ventilation, but most of the area in the region here are using the high flow oscillation ventilation. The high frequency jet ventilation is used in the States. So as you can see here, the first three modalities are having a passive expiration, while high flow, which is the having active exhalation due to the piston that it is working, and it will help making the expiration active. And this will help in the elimination of the CO2. As you can see here, that both the cycles are happening at the same time, the inspiration and the expiration, and that's why I cannot say that it is a cycle, because both are happening at the same time. So it is a wiggling rather than a respiratory cycle. So what will manipulate the gas exchange? As we mentioned, we're having the ventilation or the CO2 elimination, which is one part of importance for us, that it will be adjusted through the tidal volume or the amplitude, or the second one is the rate or the frequency. While the oxygenation, which is the other part that it is important for us, it is the PO or the map, depending on the machine. This is for the sensor medics, and this is for the Draeger, and the FA2 as well. So the bottom line application is the high CPAP oxygenation that will maintain the opening of the lung volume, and it will recruit the alveoli, and both of them will optimize the oxygenation. The other technique, which is the ventilation or the wiggling, it is the supraphysiological rate with giving a small tidal volume less than the dead space. As you can see here, this is the amplitude, which is the difference between the lowest area of the curve and the highest area of the curve. And this is the frequency. The number of high humps here is the frequency. And this is the map, which is the pressure between the bottom line and the mid, between the higher hump and the lower hump. So what will the CPAP will cause? It will give oxygenation by giving a mean airway pressure and oxygenation, and both of them is dependent on the optimal lung volume, and this will help maintaining and establishing and maintaining the functional residual capacity. What are the uses of the high frequency ventilation? We are having either late rescue, early rescue, or first line treatment. First line treatment is only available in some specialized centers. It is not in everywhere. And we are having the late rescue and early rescue, and this depends on the skills of the unit that it is using the high frequency ventilation. There is a very interesting article published by Sherry Courtney, and she mentioned that please, if you want to use the high frequency, use it before trashing the lung, because if we trash the lung with other modalities of ventilation, and after failing of all modalities, I will be using the high frequency ventilation, I will have a stubborn lung like this horse or stubborn horse that will take time and effort to heal it, because the already lung is injured. So what are the area that showed demonstrated efficacy while using high frequency ventilation? It is the severe RDS and the air leak, bronchopleural fistula, and cases that needs nitric oxide, while those who are having occasional efficacy and it will be stubborn lung are the pulmonary hypertension, meconium aspiration, neonatal pneumonia, congenital diaphragmatic hernia, and pulmonary hemorrhage. We are having two strategies while using the high frequency ventilation. Either the high volume strategy, and this I will be using at least two map above the map of the conventional ventilation, and this will be used to optimize the lung expansion, and I will be using the X-ray as an indicator for the high frequency ventilation, and I can accept the inflation of the lung up to the 9.5 ribs. So ideally to be between 8.5 and 9.5 in the high volume strategy. It is used in the pulmonary hypertension and the homogeneous lung disease. And as I told you, we'll use a map 2 to 3 higher than the map on the conventional ventilation. The low volume strategy, it is used in the cases of pulmonary interstitial emphysema or bronchopleural fistula, and I'll be using the lowest map, which is equal to the conventional ventilation or even lower than the map on the conventional ventilation. So there are many papers speaking about the side effects of the IVH, and we published a paper together with my professor, Dr. Hisham Mawad and Dr. Gamal Sami, about, it was my thesis for the PhD, and about the complication with the high frequency ventilation, and both the IVH, PVL were not associated with the high frequency per se. It was a complication of the hypocarbia, but not from the mode of ventilation itself. So the aim is to avoid the hypocarbia and avoid the hypoxemia, especially by using the high volume strategy. So we'll go for easier understanding. We'll go for a case presentation. We're having 600 grammar, 24 weekers, typical clinical signs of RDS, received Cervanta, and he was placed on SIMV with a PEEP of pressure 26/6 and FiO2 of 80%, and this is the blood gas. And the question, are we satisfied? Most of us will say no. What is the problem? We will say that it is uncompensated mixed acidosis with hypoxemia. So what we will do now, I think most of us, we will request a chest X-ray, and here is the chest X-ray. You can see a lung with small lung volume and haziness bilateral, a typical case of RDS, for which we should adjust the ventilatory steps. So what we use here for this case, shall we increase the volume? Already the baby is not on volume guarantee, so the answer will be no here. Increasing the PIP, I think it is a PIP of 26, which is very high, and it is never recommended to use the PIP alone, and that's why we could recommend to add the volume guarantee. To shift to high frequency, to increase the rate, or increase the flow, I think because of the lecture here, we'll go for the high frequency mode of ventilation, because already we are over distending the lung with the conventional ventilation, and I'm causing a lung volutrauma. So we should avoid ventilating the baby in this area where we are giving a higher pressure, but you can see inside that the volume of the lung is not increasing or not changing. So we want to come back with the lung to the reaching the functional residual capacity alone, where a minimal pressure will cause an increase in the volume inside the lung. So the baby is placed on high frequency ventilation with a map of 10, amplitude of 20, frequency of 10 Hertz, and FiO2 of 90%. And we have seen the chest wiggle, and we could win the FiO2 to 75%, from 100% or from to 90 to 75%. And we did arterial blood gas, and it showed pH of 7.2, PCO2 is 75 with oxygen PaO2 of 38. And the question comes now, shall we increase the map or increase the frequency, increase the amplitude, continue the same parameters, or 1 and 3, which is increasing the map and increasing the amplitude? As you know that in this baby, we're having a problem of oxygenation, and for that, increasing the mean airway pressure will lead to increasing the alveolar recruitment, and this will decrease the ventilation perfusion mismatching, and then, or hence, I improve the oxygenation. So to improve the oxygenation, I can increase the FiO2, I can increase the MAP, and I can augment the cardiac output to ensure adequate venous return. We advise that we use a chest X-ray to determine the overinflation, especially with the high frequency, because the flip-flop that we'll see at the end of the slide, that while using high frequency, especially the oscillator type, because of the active exhalation, I can shift between the atelectatic lung, small lung volume, to one hyperinflated lung in less than an hour. The other point in our case, we are having high CO2, so I need to wash the CO2. How we eliminate the CO2? It is affected by two parameters. The primary one is the amplitude, and the second one is the frequency. My advice for the junior doctors, wherever they are, and it is happening in every unit, that whenever they are using the high frequency for the first time, they think that the frequency is equaling to the rate. So whenever we're having high CO2, we'll increase the rate in the conventional. So we increase the frequency in the high frequency ventilation. No, in the high frequency ventilation, we will come to know that we should reduce the frequency to give more tidal volume for the during the spacing between the cycles, and giving more tidal volume between the cycles will improve the gas exchange. So increasing the amplitude will increase the tidal volume, and this will eliminate the CO2. Again, decreasing the frequency will increase the inspiratory time, and this will increase the tidal volume again, and will cause the hypocarbia, or our aim to wash the CO2. You can see it here in a more clarified way. This is the cycles, this is the frequency. This, when I'm using the frequency of 4 and the frequency of 8, when I'm using a 4, what happens? The inspiratory cycles is more, so the tidal volume is more, so the gas exchange will happen and will lead to the hypocarbia. We'll continue our case. The map now we reached 15, map amplitude 28 with a frequency of 8, and FiO2 we reached 55 with a good chest wiggle, and we advise to observe the chest wiggling to reach at least the umbilicus, or 1 to 2 centimeter maximum below the umbilicus, not more than this. If it is more than this, even reaching to the, because we have seen some cases, the wiggle reaching up to the genital area, this will be associated with hypocarbia, and this will increase the incidence of periventricular leukomalacia. So, and this is the blood gas after reaching these parameters. We can see here that our PCO2 is becoming normalizing, and our oxygenation, because this is arterial, it is acceptable here. So we decided to reduce the MAP one by one because of the fear of the high MAP that will cause a hemodynamic compromise. So we reached from 15 to 14 to 13, and when we reached to 12, what happened? The patient deteriorated, and we needed to increase the FiO2 to 65. So what happened here exactly? If you remember the graph with the critical closing pressure, we reached the critical closing pressure at 12. And hence the baby, the lung collapsed and became atelectated, and the baby needed higher oxygenation. So we went back to 13, but nothing happened. So in the practical point, when we reach the critical closing pressure, I will stand beside the baby, I will increase the MAP by 2, so I will reach to 14 back. And once the baby oxygenation is improved and I can reduce the FiO2, I will go to 13, but I will never go to 12 at that moment. For today, I will not go for 12 because I know that at 12, the baby had passed into the critical closing pressure. And this critical closing pressure is changing. So depending on the improvement of the compliance later on, maybe 12 today is not good for the baby, but maybe tomorrow I can reach up to 11 or 10. So it is a momentarily period. So the question here, what to do? Had we had a tube obstruction, pneumothorax need more recruitment or continue same parameters? Already I answered this, that the baby, we reach the critical closing pressure and the baby needs a more recruitment, and hence I will increase my increasing more recruitment for the lung by increasing the MAP. This will show us that while using the conventional ventilation, if I'm not giving the proper PEEP and not giving the proper PIP, the lung will be atelectatic. And what we should do is giving the proper PEEP and not to be PEEPophobic, and using the proper PEEP. And hence, the injurious to the lung by the delta P is minimized. So in high frequency, what we are giving, it is more or less the same at the both of the cycles, the pressures, and this will lead to a better recruitment of the lung and better gas exchange at the level of the alveoli. This will show the alveoli while during the high frequency. As you can see here, it is a wiggling of the alveoli. It is not a cycle of inflation and deflation. then this is again the lung during the high frequency mode of ventilation. The lung volume is improving, and despite of this big lung, you can see that small areas are still atelectatic, and it is indication that I can safely increase the MAP. I think because of the time, I don't have more time, so I will stop at the end of this case scenario, and I'm ready for any question in the practical session of today. Thank you very much.
مرة تانية بنشكر الدكتور أسامة حسين على دعوته الكريمة للمشاركة في المؤتمر المتميز دايما وغني بالمادة العلمية الجميلة. وبسعدني ان احنا نقدم الأستاذة الدكتورة إيمان كامل والمحاضرة بعنوان هيمودياليسيس during COVID-19 بانديميك. اتفضلي يا دكتورة.